Welcome everybody today to Ireland, to Dublin, to RCSI, and to this webinar on the UN Sustainable Development Goal 3, Good Health and Wellbeing. My name is Hannah Mcgee, and as the Chief Academic Officer at RCSI, I am really delighted to introduce and be part of this webinar. I understand we have over 600 attendees from a very global spread. So welcome to attendees from the Middle East, from Africa and from Asian countries, as well as North America and Mexico, our European colleagues and many colleagues here in Ireland. I believe all but Australia and Antarctica are on board today. The UN SDGs provide a framework to bring nations, organizations, governments, public, private and third sectors and academia together to focus on the 17 key UN goals, goals ranging from tackling poverty to education, to health and well-being, to environment. The global COVID-19 pandemic has shown us all the imperative of international collaboration, of sharing science, health expertise, logistics, resources, and so on, to tackle the world's most profound societal challenges. And the SDGs, agreed in 2015 by over 190 countries and with a goal for delivery by 2030, provide us with a common focus and language whereby we can work together to address these fundamental goals. Many universities, including RCSI as a single faculty, health-focused university, are committed to work with the UN SDG framework by signing the SDG Accord. We as universities have a major responsibility to instill in our graduates a global awareness and a sense of how they individually and collectively can contribute to progress throughout their career. And we must do that not just by our education, but also by the example we give in our institutional actions. The value of the contribution of the universities to all of the SDG goals has been highlighted and quantified by the Times Higher Educational International University Impact Ranking Scheme. They have an SDG ranking system, and in 2020, over 600 universities took part. We in RCSI have been designated as the #1 university in the world for SDG3, health and well-being. And that's an honor that is a significant source of pride to us as a small university, and it's also a challenge to us to continue in our work. RCSI contributes to SDG Goal 3 under 3 pillars: delivering health professions graduates, delivering impactful translational health research, and developing local, national, and international partnerships in health. We do this from our home campus of Dublin and also from our campuses in Bahrain, Dubai, and Malaysia. This webinar is part of our ongoing SDG3 work. It will explore how global communities can respond to critical challenges, to health needs, and to preparedness towards SDG3 in the post-COVID era. We have 4 excellent speakers for you, followed by a good time for panel discussion with your questions, and then with a concluding summary from RCSI's Chief Executive, Professor Cathal Kelly. So without further delay, I am delighted to hand you over to Professor Mark Shrime, RCSI's O'Brien Chair of Global Surgery, to introduce our panel and our session. Thank you. Over to you, Mark.
Thank you, Hannah. Thank you all for being here, for being part of this webinar, as Hannah has said, on the UN Sustainable Development Goals, and specifically on SDG3, which is the goal of achieving good health and well-being by 2030. As Hannah has said, you'll be hearing from some spectacular speakers coming to us from Geneva, from Nigeria, and from California. And then there'll be a Q&A session at the end. And they'll be talking about building toward SDG3 in the post-COVID era. But I actually want to motivate our time together for the next 90 minutes or so by presenting a thesis to you. And this thesis is based on the fact that although there are 17 distinct SDGs, those are not necessarily as distinct as they may seem, and there's a lot of interplay among them. And the thesis that I want to present is, as we think about building toward good health and well-being in the post-COVID era, if we think about building holistically and thoughtfully and listening to the stories behind the patients that we see and we talk about, we might stand to improve not just SDG3, but also SDG 1 and 4 and 5 and 17. And to present this thesis to you, let me actually present a patient to you. And I apologize from the outset for the slightly graphic nature of this picture that I'm going to show you. This is a patient of mine from over a decade ago when I was working in West Africa. Her name is Blessed. She has a disease called NOMA. Now, if we're honest with ourselves, those of us who work in health tend to think of Blessed's story as basically starting the minute she enters the hospital doors, and it ends once we discharge her from surgical care. And with that framework, we tend to look at a picture like this in a particular way. We start to catalog the health effects that Noma has had on Blessed's face, catalog the fact that she's missing her upper lip and even more of her lower lip and some of the columella of her nose, et cetera, et cetera. And as a surgeon, I do this cataloging and then start thinking about the procedures that I'd need to do to reverse the health effects that Noma has had on Blessed's face. But for today, I'd like us to take a step back. And I'd like us to listen to the story behind this picture. Because if we do that, we start to hear an interplay of a whole bunch of different forces behind this picture. Hear the outlines of a deeper, interconnected, systematic issue that manifests in a picture like this. So let me tell you Blessed's story. If you don't work in Sub-Saharan Africa or South and Southeast Asia, it's likely you haven't seen Noma before, because Noma is fundamentally a disease of malnutrition, of poverty, and of poor oral hygiene. The last time Noma was reported, at least that I could find, in a high-income country was in a single case of an immunocompromised child at the beginning of the HIV epidemic. And prior to that, it was seen in the Nazi concentration camps in World War II. So very much Noma is a disease of fundamental inequity. And what happens with Noma is the child overcomes a systemic infection. Classically, it's measles, although it was not the case in Blessed's case. Overcomes a systemic infection, the immune system is knocked back because of the systemic infection and is unable to keep the normal commensal bacteria in the child's mouth and nose in check. On a backdrop of malnutrition and poor oral hygiene, those bacteria basically run rampant and they cause a necrosis of the midface. But the interesting thing about Noma is that if you are able to get the patient to the hospital fast enough, get them on a regimen of IV antibiotics and good oral hygiene within the first 48 or 72 hours, you can actually arrest this process. But if you don't, it basically has to run until it burns itself out. And you turn a simple infectious disease into a complex reconstructive surgical problem. And that's what happened with Blessed. It took some time for the family to recognize that hospital care was needed. And once it was recognized, it was difficult to get the patient to the hospital because she lived far away from it. There was no transportation. And also because taking her to the hospital would leave the other children in the charge of the father, which was not necessarily viewed as perfectly acceptable. When she got to the hospital, she was placed on IV antibiotics. At that point, it was too late to stop what was happening in her face, but she was placed on IV antibiotics and she stayed on IV antibiotics for months, only being discharged when the money ran out. She was discharged home. Understandably, she did not want to go to school. She stayed out of school until she finally got her definitive procedures. It took 17 procedures in a partnership between a local plastic surgeon and some missionary surgeons that were in the country to reconstruct Blessed's face. So if we step back from Blessed's picture and we start to listen to the story behind it, we see that disease has an impact on a whole bunch of domains. An impact definitely on health, but as well an impact, as we saw from the last slide, on the patient and the family's financial status, an impact on a patient being able to go to school or go to work, and fundamentally with the distribution of disease around the world, these questions that we're asking are questions of equity. So when we first see Blessed's picture, we see SDG3. And as we start to peel back the layers of the onion, we start to see questions around SDG1 and 2 in malnutrition, around access to quality education, around gender equity. Fixing the surgical problem allows Blessed to go back to school. And I'll tell you right now, she's studying to be a nurse, so allows her to get decent work and contribute to the economic growth of the country. And fixing the surgical problem required a partnership across sectors. Health is unique in some ways in that it crosses these sectors. And treating Blessed's surgical condition, if we do it right, if we build towards SDG3 in the post-COVID era, is more than just creating new lips for this child. It is starting to address all of the other issues that the SDGs bring forward. And with that thesis being presented, let me introduce our speakers. So as I said, we'll have 3 speakers. We will have Professor Abraham Verghese, who's coming to us from California, where it is just past 7 in the morning. So thank you for being here so early. We'll have Dr. Gaya Gamhwwage coming from Geneva, Professor Emmanuel Ame coming to us from Nigeria. As Hannah has mentioned, There'll be 25 minutes of questions after these talks. The questions can be typed into the Q&A window that you have. I'll be asking the questions of the panelists. If there's a particular panelist that you would like the question addressed to, please just put that in the chat box. Finally, after the question and answer session, Professor Kelly will close this off. Professor Kelly is going to ask if you all have thoughts, suggestions for future SDG related conferences, and there will be an email in Professor Kelly's slides where if you do have questions or thoughts, please do feel free to get in contact with us. All right, so with that, let me introduce Professor Verghese. Professor Verghese, thank you for being here. Professor Verghese is the Vice Chair for the Theory and Practice of Medicine at the School of Medicine at Stanford University. He's also a best-selling author and a physician with a reputation for his focus on healing in an era where technology often overwhelms the human side of medicine. He received the Heinz Award in 2014. He received an honorary doctorate from RCSI also in 2014, and was awarded the National Humanities Medal by President Barack Obama in 2015. Professor Verghese is perhaps best known for his books, for his writing, including My Own Country, The Tennis Partner, and Cutting for Stone. Professor Verghese, over to you. Thank you for being here.
Thank you so much, Mark. It's such a treat for me to be part of this conference, and I remember very fondly my visit to RCSI. Thank you for having me. I'm going to share my screen and begin with my slides. So I'm so glad that Mark began with the story of the patient you heard about, because that's what I want to focus on. I want to focus on the story after the story, and really the story of all of us involved in healthcare. We are living through the story of our lives. In America, this is just a partial snapshot of the healthcare workers who have succumbed during our COVID epidemic. Amongst them, as you can see, a disproportionate number of people of minority and of color, approximately 100 physicians at the last reckoning. So this has been a very, very personal story for all of us in healthcare. And reading some of the narratives of nurses and physicians and the struggles they're going through, you can't help but be moved by this experience. And so I took as the premise that healthcare and our UN development goal for health cannot really begin without the health of the healthcare force. And so I want to focus a bit on that story. We're all living through multiple layers of stories. At one level, it's the story of our cells and our cells' receptors and our vulnerability to this virus. It's the story of our bodies, our particular age and vulnerability, the story of our lives being affected by this viral illness, our families. My two adult sons moved back home a couple of months ago, and in the process of trying to deal with this epidemic, losing jobs. All of us worry about our jobs, our future, and of course, the issues unique to our towns, our state, our country, and the world in general. In America, it seems like we've been faced with so much political turmoil, so much climate turmoil, not to mention the virus, all at the same time. And the question for any storyteller is, how will this story end? Will it end as it did with the Great Depression, with a long period of economic downturn? Or will it be a dramatic ending, very much like the discovery of the polio vaccine, which very quickly ended the nightmare of polio for so many parents? And I think that the vaccine story with this virus has been simply amazing. These are the two individuals who pioneered the mRNA vaccine, which is truly transforming our landscape. So in the minutes I have, I just want to remind you about story. What makes something a story? For something to be a story, you have to have a conflict, a crisis, and then a resolution. Or in the words of Hollywood, drama equals desire plus danger. Someone needs something, there's an obstacle in their way, and that is the formula for drama or for story. And I think of the prototype of a conflict or a story as Jaws, which happened to be the movie that I first saw when I came to America in the 70s, living through my own particular story. But it was this movie made by an unknown director by the name of Steven Spielberg, about this monster emerging from the deep and threatening this peaceful community. I think many of us couldn't swim peacefully after this movie. But many years later, when I got more involved with screenplays and with the business of writing stories, I came across the storyboard for Jaws. And it struck me when I looked at the storyboard that this storyboard really had echoes of the very first recorded story known to man. We think that the very first recorded story is the Epic of Gilgamesh, recorded on these cuneiform tablets, in cuneiform script. It was discovered only in the late 1800s, 1900s, but it was its origins is in 2000 BC, and it tells the story of the hero Gilgamesh and how he conquers the monster Humbaba. Prior to that, everyone assumed that the first story ever was that of Beowulf, where Beowulf tackles the monster Grendel. And since those two prototypes, there have been any number of monster stories, especially ones that are dealing with an outside force, a plague, most famously Camus' The Plague, but also Boccaccio's The Decameron, Daniel Defoe's Journal of the Plague Year, followed by a whole slew of famous books and stories that have the same prototypical theme, not to mention a whole host of movies. So what is the construction of a story like the one we're living through? Well, typically it has the following parts. There's a monster who's undefeatable, who suddenly appears and must be appeased at great human cost every single day. The monster has allies. The allies are climate change and fire in California. The allies are political protest and public dissension. The allies are poverty, health inequity. But along emerges someone, typically an ordinary person, an ordinary citizen, called to adventure, who becomes the hero or heroine. Or this could be a group of people. And typically this person puts into place special weapons that have never been considered before. And this person has a tremendous belief in the future and is able to finally tackle the monster. But that's not how the story ends. It's not a simple, we go back to where we were. We'll never go back to where we were. At the end of these stories, we're always in a new order, a new way of being, which I think is my full expectation of what is going to happen. So in short, the heroes and heroines of this story that we're living through are all of you working directly or indirectly with healthcare, all of you caring for loved ones with COVID. We are all the heroes and heroines of the story, forced to find special weapons and step forward. I want to say that we're always engaged in the story. Sometimes in healthcare, we are the catalysts moving the story along. Stories are profoundly important, which is why I'm talking about them. I think stories are instructions for living, and they are how we teach our children and future generations. Telling our stories is the way we survive. Finding our epiphany takes us to a better place. Stories educate. So all of us as educators, people at RCSI, us at Stanford, we're in the business of storytelling to educate. Camus said famously, evil in the world comes from ignorance. And so I think part of our development goal for healthcare has to be education, imparting knowledge. Murakami, another novelist that I love, says, once the storm is over, you won't remember how you made it through, how you managed to survive. You won't even be sure whether the storm is really over. But one thing is certain, when you come out of the storm, you won't be the same person who walked in. So what will history say of our story? Very famously, Santayana said that those who don't understand history are condemned to repeat it. I think history will say that by and large, we were like the ostrich with our head buried in the sand, except for the science, The science was phenomenal. As someone who came of age in the HIV era, a couple of years of not knowing what was causing this disease, a couple more years of no therapy. The pace of science with this disease has been simply amazing. The way we found the genome within a few weeks, immediately that was disseminated, we knew the receptors, we had a viral strategy, a vaccine strategy. It is astonishing. On the other hand, on the right side of your screen, we failed dismally to learn the human lessons that were already embedded in stories like La Peste and the Decameron and a Journal of the Plague Year. There is nothing, ladies and gentlemen, that's happening right now in society, all the discord and anti-maskers, anti-vacciners. There's nothing that was not described before. And I think the mark of good leadership is a real education in humanities in order to have anticipated this, in order to have predicted it better. So I want to close by saying that the health of a populace rests heavily on the health of the workforce, on all of you, on all of us. And the heroes of this story are all of you. This is a snapshot of some of my colleagues who I think of as my heroes, but I know that you can come up with a similar snapshot where you are. I want to thank my colleagues for helping me. I'll close with this quote. We have to heed the call to adventure. We have to find the tools and weapons never thought of before. We have to have courage and have faith, because this too will pass. Thank you very much, and a shout out to my team. And I'm turning this back. I'm stopping my screen share right now.
Thank you, Professor Verghese. That was incredible. We turn over to Dr. Gaya Gamhwwage. Dr. Gamhwwage is a medical doctor and public health expert with nearly 3 decades of experience in the public health sector. She's worked with the WHO for 19 years, most of that time leading capacity building initiatives and programs. She currently leads all of the learning, training, and capacity building for the WHO's emergencies program and is responsible, among other things, for COVID-19 training. Dr. Gaya is also responsible for developing WHO's first ever global learning strategy that is set to define the future of learning for achieving public health goals. Dr. Gaya, over to you.
Thank you very much, Mark, and thank you, everybody. I'm really grateful to be here. So I want to say good morning, good afternoon, good evening to everybody, the 600 plus people who've joined this really important conversation. When I first joined the international world, the World Health Organization, nearly 2 decades ago, I often thought, what is the meaning of international agreements like the SDGs? And today I see the commitment of RCSI, I see the commitment of governments, academic institutions to actually adopt, apply, and move society forward with these agreements. So I feel personally very, very gratified. If I may, I will share my screen, and here I am. I wanted to focus a little bit, especially after Professor Verghese's really interesting and thought-provoking intervention. I wanted to look at the role of learning in achieving the SDGs. And for me, this has been quite a journey, because the SDGs talks about health, SDG3 talks about education, but it's exactly as Mark said, how do we do the work of linking the separate SDGs so that we actually focus on the goal, the ultimate goal of eradicating poverty, promoting well-being in all aspects, not just health, but societal, financial, social, spiritual. And also, how do we figure out what else needs to be done to achieve the SDGs? For me, the SDGs are really about equity. And we need SDGs because of lack of equity. As Professor Verghese has said, the COVID pandemic is the biggest event to affect the human species and our planet in more than 100 years. The effects are devastating on a personal to a species level. What it has done is it has very much laid bare, really exposed the inequalities that were already present in society. And what some people are saying is COVID has exposed inequities, and inequities are fanning the flames of the spread of COVID. Another thing that we have seen quite tragically is the huge disparities in countries' abilities to cope with and recover from the COVID-19 crisis. There is a big difference between countries, and there are very big differences within countries. So today I just saw a tweet just now, just as I was getting ready for this seminar, our Director General, WHO's Director General, Dr. Tedros, he said very clearly, he said there is vaccine nationalism. Today there are, I think, 42 or 44 countries rolling out the COVID-19 vaccine, and 36 of them are high-income countries. So all the discussion on being equitable in making sure the fruits of this remarkable progress of getting the vaccine is shared by all, we're still falling short of that. And there is a very big risk, not just to our health, but to our societies and our systems because of that. Okay, so this is about looking at the SDG3 coverage and thinking about how it is linked to others. We have to really remember, as Mark's story talked about, education contributes to health. Health contributes to education. Gender, innovation, poverty, malnutrition, all of this are part of exactly what we are talking about. And if you will just give me a moment, I think I've lost myself. I can't see the full screen. There you go, I've got it now. So today, before the COVID-19 crisis of a year ago, only 5% of countries were on track to meet SDG3. Now, this is a really scary figure, because that means 95% of countries were off target. What I've discovered working for health systems, health equity, and health emergencies is that we need real-time education, training, and learning in health. We need, of course, as universities, academic institutions do, to improve how we deliver learning for the health workforce. But we also have to remember that during their working life, that health workforce requires lifelong learning. The figures that you will hear are, we are short of 18 million health workers to satisfy the health needs that we had prior to COVID-19. You'll also hear and read many studies about burnout, people leaving the profession, people who are just not able to cope, even if they manage to survive the COVID-19 pandemic work. Another very damning fact is that it can take up to 10 years for WHO's public health guidance. I'm not talking about medical guidance, but public health guidance to reach the front line. So really all this leads to us contributing to that question that Professor Verghese asked. So what is this new order and what will it look like? From my point of view and the work I've been doing, I really think we need to revolutionize how health workers are able to access lifelong learning for health across their careers and across professions. We know that digital technology and biotech are revolutionizing the world, but the fruits of this are not being accessed equitably. There is the shortfall of healthcare workers, and this is mainly felt in low and middle-income countries. Another important fact is 70% of the global health workforce are women. They're the least paid, if they are paid, they're the least recognized, and they have least access to education and decision-making. And the digital divide is real. Some of the data coming out of the International Telecommunications Union is telling us that, for example, in Africa, it could be as little as 20% of women in Africa have access to broadband internet. And remember, families in Africa having to take decisions about, do they pay for broadband internet, or do they pay for education, or do they pay for health? Next slide, please. So the challenges are very clear. In order to achieve health for all, and you've seen in SDG3 targets, they're mainly about the traditional health indicators that we care about: maternal health, child health, sexual reproductive health. And it'll be very interesting for you to note that the reference to working and responding to health emergencies comes all the way at the bottom on an additional target related to the international health regulations and preparedness and response. And what we've seen is most of the lifelong learning for health is focused on medical, nursing, and other professions. But public health requires a wide variety of disciplines to come together. And there isn't this support for learning for all these disciplines that contribute to health. And particularly, there is a particular group, that is you and I, as ordinary citizens, where our health literacy has to be enhanced and improved. Many of us are using old-fashioned educational techniques, and I'm sure RCSI is using modern techniques, but I see a lot of education for public health requires us to be more, shift to more self-directed learning, use adult learning techniques more, understand that neuroscience, behavioral science, psychology plays a much bigger role in learning. The needs of the new generations that have come on after my own, I'm Generation X, barely, and we know that the millennials, Generation Z, will make up 70% of the global workforce by 2030. I'm sure many people on this call are part of that. And how do they learn? What do they want to learn? Where do they want to learn? How do they want to be accredited? COVID-19 has had a major impact on the way we run education, whether it's within institutes or it's within the job. And also there's a big gap in not just technical competencies, but what we call transversal competencies, our ability to work with others, our ability to problem solve, our ability to manage conflict, our ability to work in teams. And therefore this leads us really to not looking at an expert teaching a group of students, but really to look at learning for health in an ecosystems model, where there are millions of people who are practicing health at the front line. And I give Africa as an example because I have most experience there, where frontline workers are generating new knowledge, but we don't have the system to capture it back. Next slide, please. So again, we go back. So in WHO, we put SDG3 right at the heart, and we see our contribution to all the other SDGs. But SDG3 cannot be achieved without revolutionizing education and learning for health for two groups. For the public, and that includes me as a citizen too, for my health literacy. And of course, without addressing new and sustained lifelong learning to acquire competencies for the health workforce. And the core requirements of this is really important as well. We have to address this in an equitable way. We have to ensure quality, which I'm sure RCSI and others know very much about, but we also have to be relevant, and we have to do it at scale. Next slide, please. And this is what I referred to earlier. We really have to, somebody said a very interesting story to me, is that if you look at societal institutions from 300-400 years ago and today, the two that have not really changed are our religious institutions and our educational institutions. Now, I'm sure RCSI will prove me wrong, but the majority of educational institutions are still stuck in what we call education 1.0, where we should be already going education 3.0 or plus. Next slide, please. So that's why over the last year and a half, I've dedicated, my team and I have worked very hard on trying to frame a learning strategy for the future of public health. And we want to really look at the contribution of learning to achieve goals, individual goals, community goals, national goals, and of course, the global goals like the SDGs. And we want to do this through a creation of a culture of lifelong learning for public health, that is equitable, there's quality and scale, creating learning culture and learning organization. And this involves the ambition to transform WHO into a learning organization. And as I said before, an ecosystems approach. Next slide, please. And of course, this ecosystem requires a multitude of everybody, not just consuming education, but co-creating, monitoring, looking at research gaps, and so on. The next slide. And this is why, since COVID-19, since January last year, a very big responsibility for my team has been to create real-time learning for COVID response. And these are just some of the courses we have. We actually legally have 72 hours from the announcement of a graded emergency to get basic knowledge into the public domain, but we take a few more weeks to turn it into learning products. And we do it through an open source platform called openwho.org. If you go to the next slide. Over the last year, we've grown to nearly 5 million learner enrollments, but that's because we have provided a lot of courses for essential knowledge in many languages. And this is very important because education does not take fully into account the language and the cultural needs of the users. We've learned that speed is very important. So our vaccine courses came out as the first vaccine hit the global market. Scale is important. We've had to scale up really fast. Access is key. So we have to have low bandwidth versions, offline versions, different language versions. We even have courses in sign language. We have to make sure quality, evidence-based and updated. And as you know, COVID knowledge is being updated regularly. It is collaborative. We have to work with others, and relevance and applicability. Next slide, please. So I want to finish here. And if I can have the full screen just to say just one word before I go. Today, the clock is on and 90 million people are sick with COVID and nearly 2 million people have died. But there are many more million people suffering and dying because of health systems disruption. You know of the tens of millions of children who haven't received basic vaccines. A Landsat article highlighted that an additional 1.2 million under fives children and about 56,000 mothers are expected to die in the next 6 months unless we get our health systems working and serving populations for all their health needs. So I'm going to stop there now, but I really want to, the final thing I want to say is we have to look beyond the SDGs in order to support the SDGs. I believe learning, equitable learning for achieving SDG 3 is really important. And I really look forward to the conversation ahead. Thank you.
Thank you, Dr. Gaya. That was an absolutely fascinating discussion on the role of education. Our last speaker before the question and answer session is Professor Emmanuel Ame. Professor Ameh is a professor of pediatric surgery and the chief consultant pediatric surgeon at the National Hospital in Abuja, Nigeria. His research focuses on global surgery, on access to surgical care, and specifically on children's surgical care in low resource settings, as well as research on medical education. Professor Ameh has contributed significantly to building the health system to support safer surgery in Nigeria by leading the very first national surgical, obstetric, anesthetic, and nursing plan for Nigeria. This was completed and launched by the Ministry of Health in 2019. He currently chairs the Global Initiative for Children's Surgery and was a commissioner for the Lancet Commission on Global Surgery. Dr. Ameh, welcome. Thanks for being here.
Thank you very much, Mark. Good morning, good afternoon, and good evening, everyone. Thanks for the opportunity to share some of our experiences with you. When the SDGs were first created, there was lots of excitement that this perhaps was the time to begin to address some of the iniquities and the problems with our healthcare systems around the world. However, we do now know that COVID has shown us just how weak the healthcare systems in low and middle income countries and vulnerable populations are. But also, it has also shown us that even in settings with well-established healthcare systems can easily get overwhelmed if we don't all work together to address inequities. The last three speakers have highlighted some of the very stark and difficult situations that we face. But I want to share with you regarding some of the work we've been doing about children. The Lancet Commission on Global Surgery indicated that about 5 billion of the world's 7 billion people lack access to timely and safe surgical care. But looking closely at that, we find that about 1.7 billion children globally actually lack access to safe and affordable surgical care. Majority of these children live in low and middle income countries, and live, if you look closely at sub-Saharan Africa, up to 85% of children below the age of 5 years will require some form of surgical care before they reach the age of 15 years. If you look at the population dynamics around the world and focusing specifically in Africa, the population of children, especially those below the age of 15 years, is so huge. In many countries, like Nigeria, it's approaching 50%. However, the surgical care of these children has really not been taken into consideration, either with all the surgical plans that are coming out or with existing child health care problems. With this background, a few years ago, after the work of the Lancet Commission on Global Surgery and the WHO resolution mandating countries to include emergency and essential surgical care in universal health coverage, Nigeria set out to create a surgical plan. And we focus specifically also on children's surgery and nursing for the very first time. Most of the other NSOPs that have already been created or that are being created don't pay specific attention to children's surgery and nursing care. And we feel that these two areas are areas that have been neglected for a long time. Just to share with you some of our findings when we did a situational analysis, we found very severe gaps in infrastructure. Yes, more than 90% of our population in Nigeria can access a healthcare facility within 2 hours, but majority of those healthcare facilities do not have appropriate equipment and resources to provide the required emergency and essential surgical care generally, and for children is even more limited. And in terms of workforce, you can see that very large parts of the country the blue dots you see are anesthesiologists, and the red dots you see on the map are pediatric surgeons. But you can see that most of the country, more than half of the country, don't have enough pediatric surgeons to take care of children. Even where there are pediatric surgeons, the required anesthetists to provide safe anesthesia are not available. And this is the situation in most of sub-Saharan Africa and many low and middle income countries. Focusing on nursing workforce, from the table, you see that our nursing workforce is very severely limited. The nursing workforce that is required to provide surgical care, midwives, accident and emergency nurses, operating room nurses, pediatric trained nurses, are highly limited. And that puts the children in Nigeria and other low and middle income countries really at very big disadvantage. In terms of financing the care for children's surgery generally, in many low and middle income countries, most of children's surgery is provided at tertiary healthcare facilities. But looking more closely at Nigeria, when we did a situational analysis, what we found was that less than 5% or approximately 5% of the entire population, and the population of Nigeria presently is a little over 200 million, but less than 5% are covered by healthcare insurance. And most of children's surgery really is not even covered in that insurance, because congenital anomalies, cancers, and some of the very severe conditions we treat surgically in children are not covered. And we also found that there was a very high risk of catastrophic healthcare expenditure from surgical care, and it's even worse for children requiring surgery. We looked closely at peritonitis from typhoid fever, which is one of the very common emergency conditions in children in low and middle income countries. And what we found really it's so severe that majority of the children that come to the tertiary setting with a typhoid perforation, most of their families end up with catastrophic expenditure because of just the laparotomy. And many of those families have to find all kinds of ways to provide the finances that is required because they need to pay out of pocket. And so how do we address these gaps? The Landsat Commission on Global Surgery and the WHO resolution provides some form of roadmap and guide about doing this. And because of this, several countries in LMICs have created NSOPs, just the way Nigeria has done. But as I pointed out earlier on, children have been largely left out. And to begin to address these gaps, a few years ago, the Global Initiatives for Children's Surgery was launched, and it created a coalition of healthcare providers, policy experts, advocates that have interest in children's surgery from low and middle income countries and high income countries, bringing them together to see how we can begin to address the gaps and the inequities in children's surgical care around the world. This happened in 2016. And before now, most of efforts that are ongoing about surgical care and children's surgery really, a lot are HIC dominated, but the strength of GIGS is the fact that it's very inclusive of all groups that have anything to do with children's surgery. It's LMIC driven, which means that all the issues are generated by the LMIC providers, and with the support of HIC colleagues, we begin to try to find solutions that are context specific for LMICs, such that they can be sustainable. And the overarching goal is to see how we can change the actual on-ground situations and realities. So much publications have been made about the problems and solutions, but we are not seeing actual implementation on the ground that is changing the realities. And that's one of the things that GIGS is trying to do. And in order to achieve this, GIGS created the optimal resources for children's surgical care, which has now been launched and published. And the aim of the optimal resources is that it provides a roadmap to guide how access to surgical care for children can be scaled up, especially in vulnerable parts of the world. Before now, all the documents available were HIC focused, such that if an LMIC country decided to come up with some programs to improve access to children's surgical care, there was a problem because there was not enough guidance to support them. But that's one of the things that the optimal resources for children's surgical care has done, and it should help governments to deploy very scarce resources that they have to improve children's surgical care. And so we are at the point of implementing the optimal resources for children's surgical care. We know that children's surgical care cannot exist in isolation. It needs to exist be integrated into existing healthcare programs and child healthcare programs. And one of the things that GIGS is doing is to work with countries and colleagues in various countries, LMIC countries, to integrate children's surgical care into surgical plans and child healthcare programs. And what we hope that in doing this, we will gradually begin to improve access to children's surgery around the world. But in relation to what COVID has done, We recently surveyed children's surgery providers in Nigeria, and we found that I think one of the big realities is that children's healthcare generally, as Gaya pointed out, vaccine immunization has been severely impacted. But looking specifically at surgical care for children, we found that more than 90% of institutions that provide surgery for children had suspended elective surgery. Some were able to develop all kinds of ways to begin to address emergency conditions in surgical conditions in children without actually doing surgery. But again, one of the things we found was that some of the elective surgeries that were suspended, some of the children ended up coming back with emergency life-threatening problems. But I think one of the good fallout from it is the fact that 20% of the providers adopted non-operative protocols to manage emergency cases for the very first time. And I think that that's an advantage. We don't need to operate really all the time. And already anecdotal evidences have emerged that the backlog in surgical cases, both adults and children, has significantly increased. We know that children's cancer, and unfortunately, cancer continues to progress when care is suspended, and that children's cancer care has been really negatively impacted significantly by COVID. The training of the heavily needed providers for children's care has slowed. Many of the training colleges have had to suspend their training activities and examinations, and that is contributing to the shortage of the workforce that we presently have. But I think that COVID has also created some opportunities and realities that we can actually leverage to improve access for children's surgical care. In terms of follow-up, we now know that we can follow some of the patients virtually or by telephone. Gaya highlighted that in many low and middle income countries, mobile telephone the penetration is quite high, even though there's some inequity in the way the penetration is. But we are now beginning to use more telephones, mobile telephone, and virtual communication and social media to follow up some of our patients. We now know that previously, one of the major limitations to healthcare providers from low and middle income countries to attend international meetings and for learning purposes was the fact that the finances were simply not available. But we now know that we can do so much virtually, especially example is the seminar that we are having presently. We now know that many non-skill based training can be done virtually. We don't need to do everything physically. And I think these are things that we need to continue to build up on in the post-COVID era to strengthen our educational and training activities. Importantly is the fact that we need to begin to invest in inexpensive and innovative simulation for training, both for surgical care generally and for children's surgery, because we now know that we don't have to do everything on live patients. And with COVID, even the interaction with live patients is progressively diminishing. So we do need to begin to invest in simulation. A lot about COVID centers around infection control, and so much, I know that so much money in many countries is going into infection control. This is one of the aspects that we can leverage to strengthen surgical care, not just children's surgery, but surgical care generally. A lot about surgical care surrounds infection control, especially in the perioperative setting. Critical care is an area that has lagged behind in low and middle income countries for a long time, both the infrastructure and the workforce. And those are some of the things that we need to care for COVID patients. So with all the investment going into those areas, I think that we need to begin to make sure that critical care for surgical patients is incorporated into this. Anesthesia obviously is a major weak link in surgical care in low and middle income countries, especially for children's surgery. And we need to leverage some of the funding that is now going into COVID work to train more anesthetists. In terms of supplies and consumables, again, this has been one of the challenges for surgical care in low and middle income countries, because most of the supplies come from high income countries. And COVID has shown us that those supplies can easily dwindle. The reality is, if the high income country doesn't have enough, I know there was a time at the early phase of COVID that simple masks were a problem because they stopped coming from high income countries. And I think that one of the things we need to begin to do in the post-COVID era is to invest in producing and manufacturing some of these simple supplies and consumables within low and middle income countries, so that brings down the cost and that strengthens the supply system and the supply chain. Obviously, children's surgical care has been neglected, but with the large population of children in low and middle income countries, it's going to be difficult to actualize SDG3 and all the other health-related SDGs without making sure that children that require surgical care are properly taken care of. And I think that strengthening the surgical ecosystem to deliver surgery will put the world in a better position to respond to future pandemics and disasters. And we need a deliberate and coordinated investment in children's surgical care as part of the COVID-19 response and recovery to facilitate achieving some of the goals of the SDGs. Thank you very much. Back to you, Mark.
Thank you very much, Emmanuel, for this very thorough review of children's surgery. So I'm going to open up the floor for questions right now. The questions, there are already some good questions in the Q&A session. I want to highlight one quick question at the very beginning, which is about access to this talk afterwards. I believe, and I can be corrected if I'm wrong, I believe there will be a video of this talk is being recorded. There'll be videos of this sent out to all the participants. So with that, let me open the first question to Professor Verghese. Abraham, on some level, what's happened in the last year, especially in the US and perhaps worldwide, has been a story of conflicting stories of what's actually happening with COVID. As people who work in medicine and as scientists, storytelling isn't what we're trained in doing. How could we have told the story differently in retrospect?
Yeah, I think that's a great question. We have on the one hand wonderful science, and then on the other hand, a failure to disseminate that science and that knowledge in ways that would really save lives. And it's the great tragedy, I think, of the epidemic in America is that a society that could have taken measures to prevent it was so fractured that it didn't succeed. Coming back to Camus' quote, evil in the world is really stemming from ignorance. And I think had we been able to convince the public, we might have made a considerable difference. It would have helped if our leadership also had a consistent message, and we had such a fractured and at times contrary message, including from people in academia, including from people from my own institution who wound up being championed by our president for a message that we thought was not helpful. So I think this is something that we as scientists can address. It's a mistake to think that we can just do our science and everything will trickle down to humanity. I think we have to really invest in science communication. As someone who tells stories, I've felt for some time now, and I think there's a whole cadre of science writing that feels that the challenge is really making the science compelling and making it understandable. People are so willing to lap up false narratives. Why not, instead replace those with good narratives, with compelling narratives. And that's the challenge to us.
Thank you, sir. A question for all the panelists here regarding the equity of access to COVID vaccines and treatments. The question is, would the panel like to comment on what could be done to address this inequity? For example, World Trade Organization rules, and can pharma firms help? And why don't I turn that to Dr. Gaya first?
Yes, I suppose this is the most important question on people's minds. There was a great dialogue towards the end of last year, the solidarity principle, where we shared, everybody, the world shared very quickly the scientific data that was required to develop the vaccine. There were billions of dollars raised and committed to actually purchase the vaccine so that low and middle income countries could get it. All of this really grew over the last quarter of 2020. But when reality hit, when the vaccine became available, several things happened. And I think it was predictable, but it's very disheartening. So countries are bilaterally negotiating vaccine supply. So while there is solidarity and commitment to pay for and to distribute vaccines to the whole world, this is not happening. And WHO has been talking about this vaccine nationalism for some time. I want to link to the previous question as well. Science can give us data, can give us information, but meaning is socially constructed by societies, right? So that's why we can have, it's not just the political polarization in the world, it's not just ideological differences, but people really look, when they are under stress particularly, they look at their context, their perception, the stories that have been handed down from generation to generation. So you can have very educated, qualified individuals and groups having a belief that is in conflict with the latest science. The science also tells us that if some of us are not protected, none of us are protected. That it's not just a health issue, but our societies cannot recover. And we are so interlinked in this globalized world that if we hoard vaccines, if only a few countries get vaccines, everybody will suffer. But this knowledge is not enough. This knowledge is not enough because governments are responsible for protecting their populations. And in the political systems of today, they're going to take decisions that benefit their own populations first. And in the scarcity of resources, which is what we have now, we have a limited number of vaccines at the moment, we are going to have this reality. But then, as was said earlier, we can still choose to act differently. So what is really required is to have an honest discussion as to the impact of decisions of not having equitable access to the vaccine, and then really looking at reasonable ways of sharing that resource. But I think it is a really big mistake for us as scientists, and I'm a medical doctor by training, to say that science is more important than anything else. For individuals, we have to understand what people's perceptions and fears are. And this is where the role of risk communication comes in. And that's where storytelling is an amazing tool for this. I don't have a solution, Mark, but I think we have to be honest and we have to look at not our individualistic approach to life, but collectively what will happen to humanity, society, and the world if we don't act differently. And that would require some policy decisions, some political decisions, some health decisions, and a lot of logistical decisions for that to take place.
Thank you. I wanted to see, Ms. Verghese, do you want to answer that as well?
Yeah, I just wanted to add that I had the opportunity to talk to Seth Berkley, who runs the Gavi initiative, and COVAX is trying to supply vaccine to about 190 countries and helping coordinate. And the paradox is that developed countries like the United States have a lot to learn from small nations that have a much better track record of community organizations, a much better track record of being able to vaccinate. So we have this paradox of clumsy vaccine distribution in a country like ours in the United States, and powerful lessons to learn from Africa and Asia, where community-based organizations have been doing this so effectively for years. I thought that was such a curious paradox. This learning is very much a two-way street, and sometimes in our hubris, in our arrogance, we assume that it only goes one way. But in this whole epidemic, we've had so much to learn from the rest of the world.
Thank you. Professor Ame, did you want to add anything to that?
Yes, thank you. Just to take off from what Professor Verghese and Gaya have said, at the beginning of the pandemic situation, there was so much solidarity around the world. But with the arrival of the vaccine, I think that every country, especially high-income countries, have reverted back to a survival mode. But I think the important thing is the fact that for as long as there is a weak link, for as long as some parts of the world are not protected, then the entire world is not protected. So I think that there's no immediate quick solution, but I think an honest discussion needs to take place. We need to get back to the solidarity we all saw that was there at the beginning. Thank you.
Thank you, everyone. There are a couple of related questions here around the role of surgical care within the overall SDG and UHC framework. Let me read off one of them. It's sort of exemplary of all of them. Although over 30% of the global disease burden would be amenable to surgical interventions, we struggle to address the issue with the lack of funding being the major barrier. How can we shift global decision-making to include surgery and anesthesia across the SDGs? Maybe Dr. Gaya, if you want to start with that one.
Yeah, I'm really not an expert in this area. I think Professor Ameh is better placed to do it. But any change in, so the facts are very clear, right? So 30% could be addressed by surgical interventions. So typically in the international world, what we do is we gather the evidence, we advocate, we get coalitions to press the need. And in the global public health domain, we have a decision-making and decision-influencing body called the World Health Assembly, which is made up of all member states, 194 member states. And as Professor Ameh mentioned before, the current work on in the surgical domain and has been influenced by the World Health Assembly. So from an international point of view, I would really say, we have to keep gathering the evidence, packaging the evidence in a way that is compelling, bringing it to people who can actually make a difference. And while ministers of health are in the World Health Assembly, you will see people who can take financing decisions for funding, for donors are also linked to that. So from an international point of view, that's what I would say.
Professor Ameh?
Yes, thank you. I think that as Gaya pointed out, it has always been a problem, but I think that with the WHO resolution 6815, that has now officially mandated countries to include surgical care in their UHC programs, I think that there is now a good opportunity to begin to address surgical care. However, I think one of the problems is that for a long time, and even up to now, it's been difficult for policymakers and funding agencies to see surgical care as a public health measure. And I think, unfortunately, for a long time, as surgeons and surgical care providers, I think that we've been talking to each other. We've got all the evidences that Gaya is talking about, but we've been talking to each other for too long. I think that we, unfortunately, as surgeons and surgical providers, we don't have the right advocacy expertise. I think this is where we now need to bring in advocacy experts to teach us how to advocate. I think we need to begin to talk to policymakers. We need to begin to engage with funding agencies at a different level and not just talking within a circle. I'm sure that, I'll give you an example. Some countries, including Nigeria, most of the healthcare tourism that happens from Nigeria, billions of dollars every year, happens because of lack of access to surgical care. And if we can keep that money within the country, we will significantly strengthen the entire healthcare system. And we know that if you strengthen the healthcare system to provide surgical care, that actually makes it possible, it strengthens the entire healthcare system. So I think we need to talk to the right people and begin to engage outside our surgical circles. Thank you.
Thank you. Professor Ame, I'm going to keep you on the spot here. This question is directed towards you. In Nigeria, the administration of healthcare is highly dependent on external NGOs and therefore can stop once NGOs pull out due to either weak organizational or financial infrastructure. The question is, what options do you see for the Nigerian government to allocate a greater proportion of its GDP to healthcare?
Thank you. That's the current reality. They at the moment the percentage, the highest percentage of the country's budget that goes to healthcare as a whole is far less than 10%, and we know that that can in no way sustain the healthcare system. The country does have a national publicly funded health insurance scheme. Unfortunately, it covers very small percentage of the population. But I think that if we can find a way to strengthen the insurance system to cover, or even if we're able to cover 75% of the population, I think that the funds will be available to strengthen the entire healthcare system. Obviously, relying on NGOs and external funding agencies is absolutely not sustainable. We have to begin to look at innovative ways of leveraging finances within the country. And that's one of the things that the ENSOP is working on. We are not there yet, but we are gradually looking at all the different ways that we can strengthen the healthcare system. There's currently an ongoing Landsat Commission for Nigeria, which is actually looking and working on how the entire healthcare system in Nigeria can be really disrupted in a way that makes it strong and sustainable. And we are hoping that once the work of that commission is completed, we probably will have a better opportunity and a better roadmap to strengthen our healthcare system. Thank you.
Thank you, Emmanuel. This is for the panel as a whole at large. Universities have an important role to play in achieving the SDGs through education, research, collaboration, and public engagement. How would the panel recommend that university senior leaders realign and inform strategy to achieve the SDGs by 2030? Professor Verghese, I'll turn that one over to you first.
Well, I was hoping that Dr. Kelly would take this one on. I'm certainly not someone in a major leadership role, but I do think that all of us in leadership at the medical school at Stanford, at the university, have had a huge awakening. I mean, it began with the whole Black Lives Matter movement, which really was continuation of our original sin of 1619, when the first slave ships came to America. There's been a tremendous sort of revamping of thought and strategy. And then, of course, on top of that, COVID and the way it magnified inequities in health that we were all aware of, but not as viscerally aware of as when we began to see them in real life happening and showing up in our emergency rooms in the form of people who were essential workers who could not afford to stay home, who could not afford to shelter, and who went back to families that were packed with 7 to 8 people in one room. So all I can say is that we're not going to be the same, but I don't think I can speak more concretely than that, other than the general mission of a university is to disseminate, education and knowledge and counter ignorance. So I'll turn to the real leadership, Dr. Mcgee and Dr. Kelly, to help us out here.
Yes, Hannah Mcgee. Hannah, you're muted still.
Okay, thank you very much for the question. And I'm not sure I have a detailed answer, but I certainly do know in the last number of years in RCSI, we have been working very hard with our students on a real student staff partnership model. We all have the experience in our own education and institutions of having a single student as a representative on committees, where effectively it would be very difficult to have a student voice heard. So we've been working very hard to make that relationship much more meaningful and equitable. And indeed, I think we'll look back to say that we could not have managed the last year in the pandemic in our educational activities without the true partnership of our student unions and our student leaders. So I think even at the very simple level of how we engage, going back to Dr. Gaya's point, that education has to be much more of an ecosystem of partners who all have something to contribute. Certainly in RCSI, we are a small institution in the centre of Dublin. Some of you will know, some of you won't know, but we have a very diverse, over 80% of our students are international, coming from more than 60 countries. And we are very clear that we have as much to learn from our students, both in their age and their perspective on life and their ambitions for them from their careers, but also in the cultures they bring with them. And so I think that's one of the things that all of us have the opportunity to do, which is to create more equity in the engagements we have in healthcare and education. We're all on a lifelong learning journey, and there are lots of people who are more junior or in different roles to us that can teach us things that we don't know to improve our systems. So that's certainly something we've been learning by giving more voice to our students around issues like Black Lives Matter, how COVID is impacting on them, and generally in the organization, just more of a real partnership approach.
Thank you, Professor Mcgee. I haven't had the opportunity to introduce Professor Kelly, but Professor Kelly, did you want to comment on this?
Thanks very much, Mark. And I have a few comments towards the end, which in some ways captures the philosophy and ethos of our institution. I hope my voice isn't echoing. I mean, for me, it's all about our mission and our values. And it's a real honor to serve in a mission or led organization. And our mission at RCSI is to educate, nurture, and discover for the benefit of human health. And never has a mission been more called out than in our response to COVID. I was so touched by the speakers that have just gone before me, Abraham Verghese's emphasis on the healer, Dr. Gaya's emphasis on democratization of education, and then the practical application of that in a low to middle income country from Professor Ameh. I mean, for us, we want to create healthcare professionals who will, to the optimal of their potential, be leaders in healthcare wherever part of the world they serve in. We're aware of the need to change medical education in many of the ways that Dr. Gaya illustrated. One in particular, in addition to the traditional biomedical sciences, healthcare professionals need to understand health system sciences to better inform policy in the design of healthcare. It's not good enough for us to stand apart in an ivory tower and say that's somebody else's problem. But also the healer needs to self-care. And we put it in a very big impact or importance on the elements of our curriculum and pedagogy which support character and well-being, focusing on resilience, focusing on professionalism in the widest sense, to equip the healer to cope, and not just cope, but thrive in this era, which prior to COVID was called a VUCA era, and now I guess will be a post-COVID era. So it's an exciting challenge. It's a privilege to play a part in that challenge, and it's a privilege to serve in an organization that is defined by its values of respect, collaboration, scholarship, and innovation, and is truly driven by its mission.
Thank you, Professor Kelly. I actually want to use that opportunity of one of the things that you just said about making the healers also comfortable with and familiar with health systems. I think as a last closing question to the panel, there's a few questions here asking the panel to directly address students. So I'll read one of them. If you could give a direct take-home message from your talks today to healthcare students specifically around the world, what will you tell them in light of SDG3? What can we as the next generation do to support these ongoing projects? Let me have Professor Ame open that up.
Right, thank you. Excellent question. I think that what I would say to such the students is that you should see yourself as part of the general world community. You should see yourself beyond your immediate community. You should see how you can impact on the entire world system, world healthcare system in every little way, no matter how little it is. You should all work towards making a contribution that ensure that we eliminate inequities and disadvantages in healthcare around the world. Thank you.
Thank you, Professor Ame. Dr. Gaya.
I think it's such an extraordinary time to be a young person or a young professional or a learner in the health sector. And it's not just because of COVID, but of the technological and the social transformations that are taking place. So I have 3 messages for you. The first one is related to communicating science. Whether you're a doctor or a nurse, or you're a health policymaker or decision maker, you will have to understand and communicate science. And you have to understand communicating science cannot just be from the stream of logic and science that you have acquired it from. You have to appeal to logic, to the people's minds. You have to appeal to their hearts. It has to be emotive. And you have to address people's instincts, their gut instincts. So learning how to communicate science is going to be as important as providing safe surgical care to children. The second is, because you're in this great, what we call the 4th industrial revolution, where technology will transform not just how we communicate, but how we work, the jobs we will do. There is going to be massive upskilling and reskilling that is required for you to contribute to this field and to stay happy and employed and taking care of yourself. In order to do that, you have to adopt a lifelong learning mindset, that your learning does not finish with your postgraduate, your undergraduate, your postgraduate, and your professional continuing education, but it has to be broader to encompass other skills and competencies you need to be effective in the world. And the third is really in order to fight for equity in health, which I totally agree with Dr. Ameh, it's not just quality in health, but equity in health. You will need to educate yourself and immerse yourself in health systems, health policy, health decision making. Do not have the courage to assert yourself as a leader going forward so that you shape the world and you're not just a recipient of what is happening. You are never too young to decide you will lead in a particular area, but you need to get the competencies to do that. Communication, advocacy, analytical thinking. So go for this, what we call the soft skills, which I believe are very hard to acquire. I think you are going to shape humanity as we move from a biological form to what technology promises in the future. But you can make sure we do this in an ethical and equitable way. So I really wish you the best of luck. I have a daughter who's a medical student. I'll be watching this with interest, but your world is not my world. You are going into a very different world and you will have very different battles to fight.
Thank you, Dr.
Wow,
Gaya. Yes.
Yeah, that's a real challenge to follow such eloquent answers by my 2 fellow panelists. I just love what they had to say. I'm tempted to just not say anything. I will share with you that the medical students I worked with have been really affected by what COVID has meant. In many ways, at times medical school can feel like a intellectual exercise, and there's a level of remove that they can develop between themselves and the real emotional content of what they're seeing. And COVID has stripped all that away. And I think my advice to the medical students and students listening here would be the timeless advice of Peabody. Peabody said 100 years ago that the secret of the care of the patient is in caring for the patient. You know, I think it all begins there. Or to paraphrase that, E.M. Forster in the novel Howard's End said, only connect. And if you think about it, so many of our problems with COVID right now are the failure to connect, the failure to disseminate information, the failure to connect with the hardship and the suffering of the families out there. And I think you as medical students, you may be a medical student, you may become a physician, but you cannot lose your humanity, that fundamental quality that allows you to walk in the shoes of those who are suffering. So thank you very much for being with us at that conference.
Thank you, Professor Verghese. Professor Mcgee, did you want to add anything to this? Okay, then let me turn over to Professor Kelly, whom you've already seen, but Professor Kelly is the CEO and registrar of RCSI. He took up that position in December of 2009. Prior to that, he was a consultant general and vascular surgeon with a specific interest in endovascular surgery. He's won the prestigious Petey Prize of the Association of Surgeons of Great Britain and Ireland for research he conducted, and has also obtained first place in the intercollegiate specialty board exams. And personally, he is a great boss to work under. So to close us off, let me introduce Professor Kelly.
Thank you very much, Mark. And can I start by, I'm humbled to be amongst our speakers today. Thank Professor Abraham Verghese from Stanford University and a proud RCSI honorary doctorate, Dr. Gaya Gamhwwage from WHO, Professor Emmanuel Ame, who joins us from the National Hospital in Abuja, Nigeria, and of course our local lead and host, Professor Mark Shrime, the Foundation O'Brien Chair in Global Surgery here at RCSI. I have to say, I feel humbled and indeed extraordinarily privileged to work in a health sciences university such as RCSI, which is by definition a mission-driven organization, and where I get the opportunity to meet and really be energized, as I hope so many of you have been, by people of the wisdom and the commitment of our speakers today. I hope you found the talks as stimulating and as much a call to action as I have done. And I'd also very much welcome, as Mark said at the introduction, your suggestions for future topics on the theme of SDG3, good health and well-being, and invite you to submit any follow-up questions or suggestions to the email address, which will be appearing in a slide shortly, or to your initial contact. I'd like to thank you, our audience, for joining us and participating. Nearly 700 delegates from all over the world have joined up for this webinar and for the subsequent video recording. I think it speaks hugely to your appetite for change and your shared desire to make an impact. In a recent Guardian article, Alan Rusbridger, their former editor-in-chief of the Guardian, talked about these COVID times, if you like. I quote, "If this is the worst of times, it's also the best of times. In our anxiety, we are drawing deep reserves of strength from each other. In our isolation, we are rediscovering community. In our confusion, we are rethinking whom we trust. In our fragmentation, we are rediscovering the value of institutions. The importance and the impact of science on our universities has never been more apparent. However, we can't take this for granted, and we must be able to hold ourselves to account. As a focused health sciences university of medicine and health sciences, our priority is both patient and public health. We are committed to leading the world to better health in collaboration with our many partners. All of our strategies and decisions are driven by this, and for us, the UN Sustainable Development Goals, they provide us with a roadmap against which to set our course. It also supports us in our partnership working with international agencies who are equally focused on these shared goals for our planet. RCSI now has 12 internationally active research centers, and together with student electives in 22 countries and 45 collaborating institutions, we're committed to achieving a better and safer world for us all. Our focus on the UN SDGs also extends, as the Dean said, to our student engagement and volunteering in the community. We have excellent local and national engagement through the RCSI-led Mercer Medical Centre, located in the heart of Dublin, and providing a service to the local disadvantaged community and through our RCSI hospital group. Our students really care a lot about global issues, as I'm sure yours do too. climate change, sustainability, health, and health inequalities. The global pandemic has created a new relevance for RCSI and similar institutions nationally and globally. And when we communicate this in the context of the UN Sustainable Development Goals, it resonates with the values and principles that our students hold so dear. Demonstrating global and societal impact in education and research is hugely important to us at RCSI and in our endeavours to attract international talent to RCSI. Our focus on global surgery, simulation, and population health science are great examples of this. We've recently attracted international leaders, sparing his embarrassment, even Professor Mark Shrime, who's with us today, in these areas, and been able to demonstrate our impact in the areas of the UN Sustainable Development Goals, health and well-being. I think is a very helpful point of reference in our recruitment efforts to attract like-minded souls to our institution. The Irish government, to its great credit, is also very committed to driving forward the world's collective effort to achieve the SDGs. To this end, our government has secured a seat on the UN Security Council. We work closely with this shared agenda with the Irish Foreign Service, Irish Aid, and our National Health Service, many of whom, colleagues from whom join us today. We will be continuing today's debate and building on it at a global forum to be held here in Dublin on the 7th and 8th of July of this year, in partnership with the Times Higher Education. We hope to be able to host this event physically, which one may think is ambitious, but we do live in hope for this. But we will also be taking elements from this online event to provide virtual options for delegates across the world. As Professor Ame has said, this COVID era has shown us how easy it is to reach colleagues right around the world virtually and equally effectively as meeting in person. This Times Higher Education Impact Forum on Health and Wellbeing, to be held here in the summer, will bring together leaders and subject experts from international universities to share research ideas and solutions to address the key health conditions and diseases that impact on human outcomes right around the world. It will also provide some exclusive insights into the metrics and methodology behind the Times Higher Education University Impact Rankings with a focus on SDG3. We have found as an institution, the Times Higher Impact Rankings provides a very useful framework for us to measure and reflect on our contribution to the Sustainable Development Goals. It's also helped us to ensure that we communicate this across our institution. It helps us to operationalize it and to map things that we do well. It's a tremendous motivator to people, having them contributing to tangible outcomes. It's brought our people together to work in teams who maybe beforehand worked separately without realizing they shared a common agenda. The forum, well, I hope will be an opportunity for you to learn more about how the impact rankings can provide a new lens to reflect on our performance as global agents of discovery and societal change. Can I end this session by my sincere thanks to our panel, my sincere thanks to all of you for joining us today. I hope many of you will be able to join us again in July in Dublin, where I look forward to furthering the discussion. Meanwhile, please stay safe and goodbye from now from RCSI. Thank you.